Good evening, everyone. Thank you so much for joining us for this webinar discussing IVF success for those in the 30 to 35 age bracket. I am joined by Dr. Kristýna Frühaufová, who is from Gynem Fertility in Prague. I know I got the name right, barely.
Yes.
and I'm your host, Jessica Bourke, aka the Fertility Detective. So we're going to be diving into this topic this evening. A lot of you submitted questions in advance, which is amazing. We'll definitely be getting to those. And of course, you still have the opportunity to submit questions at any time into the question box too. As always, this is thanks to My IVF Answers and the European Fertility Society. It's because of them that you have access to all this free information, and hopefully this evening will be helpful to you. So before we kick off and dive into this topic, would you like to take a moment just to introduce yourself and the kind of work that you're doing at Gynem Fertility so that people know what is your driving passion in this industry?
Hello, Jessica. Thanks a lot for the introduction. So as you mentioned, I'm a physician at Gynem in Prague. We're running about 600 to 700 IVF cycles per year. So we're, let's say, the mid-size clinic when it comes to infertility. We're doing all types of treatments, starting with the minimally invasive ones, such as the IUIs, then stepping into the IVF and also the donor egg and sperm program. So we, in Czech Republic, we are quite unlimited by the legislation. So we are allowed to do genetic testing in various terms and various conditions. So we can perform the PGTA, PGTM, or SR techniques as well. And in our biology department, embryologist lab, we are using quite advanced techniques when it comes to the semen pre-selection.
Yeah, I could see that on the website. Loads of great technologies that you have available, which I'm sure we'll be delving into at the respective times. So I suppose the best place to start with is that if anybody's thinking about the 30 to 35 age category, what immediately springs to mind is, but hang on, I thought we're always told that the reason why there's diminished success is increasing age and therefore the impact on egg quality. So for those in the 30 to 35 bracket, you know, I would imagine they're probably less frequently seen coming in for IVF. And to add to that, would you typically recommend that people wait the full year? You know, the way the advice is try for a full year if you're under 35 or just 6 months if over 35. And I know that that can be interpreted differently. So what would you typically recommend for couples that you would see in that category?
Well, you mentioned it right. I mean, it's a definition of infertility that is widely used, that we have to keep the age factor, especially the women's age, in mind. We know that after the age of 35, the egg quality drops and it reflects in the genetic quality of the embryos. We know that if there's any genetic abnormality within the embryo, 80% of those come from the egg. So it's mainly the egg to blame on this. It does depend on what is the actual reason for infertility, because nowadays most of the women are quite well followed up by their gynecologists. So and especially with the advancement in the ultrasound technology, etc., most of the women are, for example, diagnosed with endometriosis, which is quite a common reason for infertility. And if, for example, this factor is known, then there is no need to wait for the whole year before actually starting the infertility treatment. We know that the endometriosis can progress quite rapidly. So when there is some other reason that has been already identified, then you don't have to wait up to fulfill the indication for seeking infertility treatment, actually.
And for someone who might be watching who's thinking, oh, okay, so I'm 31 and I've been trying for 4 months, but you know, I'm interested in what's being discussed with us today. For someone in that position, should we maybe run through what would be the typical things you might see in terms of secondary health, gynae conditions, or problems anatomically speaking, or problems on the sperm side that could contribute to the need for IVF at that age?
one of the most common reasons for infertility nowadays is actually the anovulation. So again, this type or this group of women are quite easy to be identified because they are lacking the menstrual cycle. So if someone wants to conceive and their periods are completely irregular, then it is quite likely that they might have some ovulation issues. On the other hand, the ovulation issues are usually the easiest to deal with. So we can use some medicaments, some tablets to induce the ovulation without the actual need for the IVF. So that's one of the groups of the patients that we need to look into. So if you want some guidance, what you should like typically be looking at when you're thinking of when you're having the planning the family, then it's whether the periods are regular. If you, for example, suffer from menstrual pain or pain during the intercourse, that's something that might like indicate that there might be some endometriosis issue. And also on the male side, one of the most common issues in male infertility is something that's called varicocele, which is sometimes visible. It's like the venous congestion at the male intimate parts, and it may actually have an adverse impact on the sperm quality. So again, like keeping an eye on your body and checking for yourself, not only the women, but also male as well.
So you're talking about in the situation where maybe a semen analysis has shown that everything isn't quite as it should be, and everything maybe is looking okay on the woman's side. She's ovulating, but that they need to investigate further because, of course, in some cases it might not be palpable. You might not be able to feel the varicocele. So maybe still seeing a urologist if they can't improve the levels. So we've got the sperm side, the kind of PCOS, FHA tendency side. Or there's obviously endometriosis as well that you noted, albeit there can be some silent cases too. So if someone isn't having pain, they might still have it going on in the background. They've been trying for a while. What about any other issues, like, for example, anatomically speaking, if somebody hasn't had their tubes checked?
Well, we usually say that if the woman hasn't been through the pelvic inflammation process, and this is not, I'm not speaking about the vaginal infection, I'm speaking really about like fevers and pain and discharge that has to be treated with general antibiotics, then the likelihood of having at least one tube working is more than 90%. So if you didn't have a symptomatic inflammation, then most likely anatomically the tubes are going to be fine. The only exception being the chlamydia infection, which can actually be silent in women. It does present itself with symptoms in men. It doesn't in women, so it may run for years with having the late impact on the tubal functioning later. So
but presumably it would still be a requirement of proceeding to IVF that, you know, a hycosi had been done to check that the tubes weren't blocked, so that you knew what was going on. You know, is it the case that the tubes are blocked and that's why it's moved straight to IVF, or is there something else going on? So it would be the anatomical side. And what about any other issues? Any other secondary health problems, immune, anything that you would see that you think this might put them in the category of needing IVF at a younger age?
Well, there might be some autoimmune conditions as well. So again, part of the investigation before the actual IVF process is like checking the thyroid function, because this is usually interconnected with infertility. So if we see that there's a tendency towards the autoimmune disease, then we're looking into the immunological side of the infertility as well. And what we need to do, and what we need to check each time is we need to listen to the patient. So we have to be quite thorough on their medical history and also ask about the family medical history, because you might actually dig something out when you just, the disease that run in the family. There might be some coagulation issues that are typically inherited. So you really need to be quite thorough on that.
Yeah, so there's the blood clotting and the immune side as well. So there can be a lot going on, which is important to be mindful of, because again, that assumption that, being of a younger age automatically sort of saves you from any fertility struggles. I think it's important to state that that isn't the case, because very often people, they blame themselves, or they feel, God, there's something really wrong with me because I can't get pregnant at this age. But as you can see, to anyone who's watching, like it's really quite complicated. So it should never be a blame game. That's really important.
Yeah, and one thing I would like to mention is that what we also see is that we see quite a high percentage of overweight and obese women, even at a young age. And also the weight issue might actually be quite interconnected to infertility, because basically the excess of the fatty tissue is creating sort of pro-inflammatory conditions that are working against the implantation. So, and also obesity is connected with PCOS, so there's an anovulation,
such as well, insulin resistance as well. Yeah. So in terms of what's going on internally, and what would be impacting implantation from larger body size, correct? Yeah. Sorry, I know there's a bit of an internet delay, but we're hearing you. And so, with regard to the number of cycles, so maybe let's get clear, because I know this can confuse people. When we're talking about, as I'm sure you have to every day in clinic, about statistics and odds of success and how many cycles, when we're talking about a cycle of treatment, are we talking about a retrieval cycle and including any and all embryos from that cycle that might be transferred? Is that one cycle?
Yes, that's one stimulation cycle. Basically, it's how many eggs are you able to retrieve with one single stimulation, then fertilizing, and how many embryos, blastocysts you have in the end. So that's one stimulation cycle. So there might be lots of variables in that. So you may have anything from 0 to 15 embryos in the end. So you can actually have a big family from one IVF cycle, and you may have none. So it's all dependent on, first of all, the ovarian capacity. So that's one point. And also the male factor, because it's not only the egg that we need.
You need the sperm too. So I presume if you were then, it would very much depend on who you're speaking to, that if you were dealing with a couple where maybe there was PCOS as a factor, larger egg count in terms of the ovarian reserve, higher likelihood of success after maybe 1 or 2 cycles by comparison to someone with ovarian insufficiency who might need even 3 cycles just to get one embryo, I presume.
It's not that easy, actually, because in the PCOS we know that the egg quality seems to be diminished. So that's one of the factors as well. Generally, we know that the target or the optimal amount of mature eggs to obtain from one stimulation cycle is anything between 8 to 15. Anything above 20 is not influencing the pregnancy outcomes at all. So it's actually, it reaches some kind of plateau, and then it actually has an impact on the egg quality. So the more eggs you gain doesn't mean the higher the chances. On the other hand, it's the age that plays the most important role when it comes to the egg quality. The AMH itself won't tell us anything about the egg quality. It will only tell us how likely is it that the ovary is going to respond to the stimulation, and approximately what doses we should use to obtain the optimal number of the eggs.
Just to say on that point, because that's really important what you just said. And I know from many Irish people that I've spoken to, both here in Ireland and around the world and in the UK, that very often people are led to believe if they got too many eggs, which is usually due to being overstimulated. So it's the clinic's fault for overstimulating them. And, they've 40 eggs and they're being told, this is amazing. You've loads of eggs. But just, it's really important to hear you say that there is a law of diminishing return, that beyond a certain point, and it makes sense. I mean, how can the body nourish so many eggs? It doesn't make logical sense that would be feasible. So that sweet spot of, like you said, around 15 to 20, like it shouldn't really be going above 20, is great to hear. And also about the AMH, the fact that it's not indicating the quality of your eggs, but it's a very useful tool for you to be able to gauge, okay, how much medication does this person need, so that they're not likely to overstimulate, or they may need an extra push if the ovarian reserve seems low.
Yeah, exactly. There's actually quite a useful tool when you want to get the idea how many eggs you need to get a certain probability of having a euploid blastocyst for, let's say, each age category, combining with the source of the sperm. So it's called the egg calculators. It's available online. You can without an registration, you can just Google it up and you can use it. So you enter the age of the woman, then you enter the source of the sperm, whether it's ejaculate, whether it's a T-cell, mesosperm. What is the reason for azoospermia if you're using the surgically gained sperm? And then you enter the threshold for probability of having euploid embryo. So generally around 80% is quite a high likelihood. So for example, for this age category that we are speaking of, if you have a normal sample for semen, or if you're using the ejaculate sperm with more or less bit diminished parameters, but not too pathological, then to obtain one euploid blastocyst, 6 to 8 eggs should be sufficient.
Right, in that one cycle.
In one cycle.
Okay.
If we're using, for example, T-cell sperm with some reason for genetic or immunologic reason for the azoospermia, then you actually need 9 to 12 eggs, because you need more to have the higher probability.
Maybe we should touch on that and explain it a bit more to anyone, because I'm conscious of someone who might be watching and maybe they received a semen analysis result from the partner that shows that the count is very low, maybe only in the hundreds of thousands rather than millions. And they're hearing this and they're thinking, what on earth? What do you mean sperm retrieval, and what's MESA and what's TESA? So maybe we should break that down. And obviously azoospermia, meaning no sperm in the ejaculate at all. Because there's obviously different reasons from obstructive to non-obstructive. So let's go into that for anybody who's maybe scared, who's listening.
Okay, so let's start with the azoospermia explanation that pops up when there's no sperm found in the sample. So when male partner is sent for the semen analysis and there is 0 sperm, then it's indicates the azoospermia. What we usually suggest is to repeat the sample again, because we want to make sure that it wasn't due to, like, there might be some also psychological reasons that it wasn't the right sample to be handed over. So just to make sure that we're doing the analysis right. When the result comes back as, again, the same, then the man is usually referred to the andrologist. They have to search for the reason for this condition. As you mentioned, it might be obstructive, non-obstructive. The obstructive means that there is a sperm, normal sperm created in the testes, being made, but it somehow it cannot go out. It's usually due to the blockage. In some cases, it's post-inflammatory, or it's typical when, for example, the male had a vasectomy. So that's one of the typical reasons for obstructive azoospermia. The non-obstructive one means that there is non-sufficient production of the sperm. And there might be several genetic conditions that are linked to this condition. It also might be immunological, like in the female partners, the immune system might be attacking the cells inside the testes, causing the malproduction of the sperm. So we need when it is this kind of scenario, we always need to look for the cause, and of course to rule out the most common ones, and then just see whether there is a chance to obtain the sperm surgically from the testes. Because, for example, if you find out that there is a genetic reason for that, in some of the cases, we know that with almost 100% probability, there won't be any sperm found in the testes. So there is no need to do the surgery. If we know that there is a possibility, then the surgical aspiration of the sperm is one of the options before starting the IVF process.
And important to say, it's not something to be scared of. I mean, women go through laparoscopies every day. Now, granted, I know it's not the same as embolization for varicocele. It can be a bit more involved. And there is a difference between the MESA and the TISA, the difference between the aspiration versus actually taking a sample of the testicular tissue. But nonetheless, I've seen plenty males who've gone through it and they're okay. and they're able to tell the tale afterwards. And ultimately, if that's what's going on, I know it can be very stressful, particularly for young couples. You're often at a stage where you're just kind of starting out in life, and you're starting to try, and then to be receiving that news that there's no sperm in the ejaculate. I've received those messages, of course, as I'm sure you've have as well, and they're totally devastated. But it is important to know that, assuming that it isn't one of the more extreme genetic situations where there might be no sperm being made, and fair enough, then you have to look at the sperm donor. Ultimately, there can be lots of reasons, from anatomical to infection, to toxin exposure. There's lots of reasons, diet, lifestyle as well, in some cases, that can be causing the diminished sperm production, hormones as well, the testosterone. There's loads to check. So don't panic is the point. Getting those investigations makes a big difference.
And also, what actually makes the huge difference when it comes to the success rate is the age of the female partner on this. So again, the younger you find out, the better the chances, because when you have an issue on one part, the better the quality of the counterpart, then the higher the stakes.
And from what you've seen, how much difference would there be between, let's say, this person at the 30 to 31-year-old end of the scale to the 34 to 35-year-old? In those few years, is there much percentage difference that you would see?
We're speaking only about few percent. It's not like... Well, the age of 35 is like set arbitrary. It's not like, it's not that once you turn 35, it goes downhill. But,
yes, I was just going to say, I've seen women who, they think they wake up on the day of their 35th birthday and that's it. The egg walked out of the building, and it's not really like that. But you can understand, to everyone watching, it is difficult for you as the person sitting in front of them, having to answer these questions based on the maths and the statistics, when the research is great, but ultimately it's still a generalization. It's the best we've got, but of course, it's you who's reading them between the lines and figuring out, okay, what's likely to be impacting this particular individual or couple. So it's not a case of just 35 and that's it. So
sorry to jump in, but actually what's like the optimal, when you want to mention the optimal age for fertility, is between 25 to 28, actually. That's when the AMH is naturally highest, and that's when the rate of aneuploidies in the embryo is lowest. But when you look at the data, actually the likelihood of having an euploid embryo when you're 18 is the same like when you're 35.
Wow, interesting. From 18 to 35, the same chance of a euploid embryo. So of
aneuploid.
Or aneuploid. Sorry, aneuploid. Apologies.
So actually, very
damage.
young women do have the same likelihood of having chromosomally abnormal embryo,
Yeah.
like the ones that turn 35.
Yes.
And then the rate of the abnormal embryos go down between
Yes.
25 to 30, let's say. That's the optimal age.
Yes.
And after 35, it goes up
It
again.
goes up again.
So it's like this.
Mm-hmm.
So
There's
it
just
doesn't.
the minor detail of all the economic and social reasons for why people aren't having kids in their mid-20s. So I suppose we have to work with what we've got, which is the reality of so many conceiving in that age category and older, well into their late 30s and early 40s. So back to that initial question. I know we've gone in a circuitous route, but I'm sure it's information that was helpful. Going back to that typical number of cycles. Let's say the goal is someone says, okay, I'm 32. We've been trying, it's not happening, for whatever the reasons might be. I'm sure that plays into it. But if we're able to get an egg and sperm and the internal environment is looking okay and we're going for IVF, how many cycles is it likely to take that couple to have maybe 2 children, for example?
Well, I would say that with almost 95% probability to have one healthy child, you need 3 transfers of good
3
quality embryos.
transfers. So not necessarily 3 cycles. That could come from 1 cycle with a fresh embryo transferred and then 2
exactly.
Yes. Okay. So that's, potentially very doable in some cases and not so much in others, depending on how many embryos they get. So that's a key thing to note. So yes, I think what I'm going to do now is move to the questions because there's quite a lot of them in the comments. I hope that overview has helped everyone because it's always important to give things context. So I'm going to pop this question up so you can see it there. This person writes, 4 months post-laparoscopy to unblock the tubes, diagnosed with mild endometriosis and low AMH. And only last week, a scan showed small cyst on the ovary. I've never had cysts before. Is there any supplements I can take to help while I'm on the wait list for IVF? I'm already taking omegas, prenatal, vitamin B and D. Sperm results all normal and my cycle is regular, 29-30 days, although ovulation looks early at days 10 to 12.
Okay, I don't have the CDH of the woman asking. It's also one of the first thing that we would like to know
the age.
in the terms, to have some idea about the likelihood of this particular patient getting pregnant. So you mentioned a cyst. The cysts, most of the cysts might be so-called functional, which means that they sort of appear throughout the cycle and then just go away with the menstrual bleeding. So what we do I'm speaking of the Czech environment, is that we usually ask this patient to come again for a scan after the menstruation and see whether the cyst has been gone or not. Most likely it will be. Also, as you mentioned, might also be endometriosis on the ovaries that will stay, so that should be confirmed with another ultrasound. In the terms of the supplements, what you listed, I think, should be enough. Actually, there is no magic supplement when it comes to improving the egg quality.
I think she's referring more to the cyst as opposed to the egg quality.
Well, if it's the functional cyst, it will just resolve itself with.
If it's functional cyst, it should go. I have seen research on NAC for endometriomas, as in N-acetylcysteine. So that might be something to look at if it's felt that the cysts are related to the endometriosis. But of course, yes, if it's functional cyst, the body will do it.
It doesn't actually need any supplements.
Any intervention. So best of luck. I hope that helps that person. This person writes, what chances of success with IVF where previous total IVF failure cycle, 0 embryos, husband 32 years old and has poor sperm morphology, so that's the shape of the sperm. I'm 34 years old and I have low ovarian reserve. So what would you recommend to her?
I don't know exactly what low ovarian reserve means. If we're speaking about, there's something to categorize the patients into the prognostic groups that's called Poseidon. So this patient most likely with a lower AMH should fall into the Poseidon 3 category, which means that she's young still, but most likely we are going to obtain few eggs with the stimulation, combined with not optimal sperm results, of course, might lead to another IVF failure. I don't know whether any semen preselection have been used, also depending on the semen parameters. What actually helps to find the best quality semen for fertilization prior ICSI, of course, is the microfluid chip that actually has very good data on improving the pregnancy outcomes.
Okay, let's rewind a little bit for people who might be aware. So if they've done the first cycle was IVF, they maybe didn't do ICSI. That's what it sounds like to me. So for someone who hasn't gone through that process, so IVF, they're just in the petri dish, the sperm have got to do their thing. But with intracytoplasmic sperm injection, that's where you can help in cases like this. They might have been suggested it with the morphology, but she didn't mention ICSI. So that'd be like step one. And then what you were saying there, the sperm selection techniques could go alongside with that. So let's explain those to people, because they are quite interesting. There's different ones and differing degree of benefit potentially for the sperm. So which was the one you were referring to? You were talking about the microfluidity technique.
Yes, the microfluid chip.
Fluid chip.
Yes. But there has to be sufficient concentration of the sperm, which we don't know.
Exactly.
So, but there are different nowadays at the market. There are something that's called the ICSI chip, which works with a lower concentration, around 1 million per milliliter. So
as opposed to over 5. Because she didn't mention low count. It was only the morphology, so we'll have to assume that it was okay. But yes, there's lots that can be done there. And I think, when it comes to total fertilization failure, I think it's important to state as well that one bad cycle, particularly at a younger age, and particularly with, the morphology of the sperm, it could have been just a bad batch of the sperm. It doesn't automatically mean that that's it. That's how it's going to continue. Because I'm sure you've seen that, you can really have a complete 180 with the outcome of one cycle to another. So don't be too hard on yourselves, because I know that's an intense thing to go through at that age. So best of luck to them.
And also what should be worth revising is the type of the stimulation protocol. What was the response to the stimulation, whether there was sufficient percentage of the mature eggs versus the number of the growing follicles. So there's lots of you can actually do when it comes to like changing the whole setup of the cycle.
Delighted to hear you say that, and well said, because this goes back to the thing of people blaming themselves. It's so important to have that review appointment and discuss the protocol, everything from even the type of trigger that was used or the timing, or, there's so many aspects to the protocol that, of course, if you don't know, you don't know. So if you're unaware of what to look for, it can be very difficult to gauge. So why did it not work? Why were there not as many mature metaphase 2 eggs or not? So definitely have that deeper discussion, before taking next step. So thank you for raising that. So important. I often see that being overlooked. So somebody else writes here. Let's look at this one. Tips for Joule factor. So 2 things going on: low and slow sperm. I love that description. Low and slow sperm. So low, count, or I presume low and slow. Yeah, so low count and motility, and PCOS. So what would you do in that situation? Usual number of rounds with these types of factors and the recommended supplements for both. So that's an interesting one.
Well, we don't know the age again, so that's another. But most likely it's going to be younger patient, even though that we do see PCOS patients in their 40s as well, but it's not that common. So what I would like to see if I was to have a discussion with this kind of couple would be how does the woman look? So whether it's the obese type of PCOS or whether it's the lean PCOS, because then you have to choose a completely different approach when it comes to the IVF stimulation. When you have overweight patients, of course, you have to go up with doses.
because of tissue saturation.
Yes. Having a bit high risk of the OHSS overstimulation in those cases. When you have a lean PCOS patient, you start with low dose and you just go gradually up if needed. So again, just keeping the optimal age, the optimal number of the DX on mind, trying to aim for that, which in PCOS patient is sometimes hard.
Yeah, so not too many, just getting it just right.
Yeah, just right response. So maybe just aiming for a bit lower numbers than just having the overstimulation. With the semen quality, I don't, from my perspective, is not such a huge problem, because if there are some decent concentration, yes, we will just do the intracytoplasmic injection. So in general, if we are able to get the stimulation right, getting the appropriate number of DX in response, and the patient is young and not overweight, then still what I said at the beginning, like 3 transfers should be enough to have a healthy baby in the end. But
yes, you're right about the age thing, though, because my brain is just thinking of what she was asking about the supplements, because that's an area that I would be focusing on a lot. And I suppose if it's higher age PCOS, okay, you might be looking at more ubiquinol, as in CoQ10 and NAD and things like that, to support the mitochondria. But if it's in the 30 to 35 category, maybe it's more focusing on the insulin resistant side. So the myoinositol.
Yes, if there's any, because
because it depends on, of course, the size. There's a lot of variables. And for the sperm, tricky one too. You're usually looking at a combination of antioxidants, but also, as I'd always say to people, figuring out why, like what could be going on that's causing the low sperm count. It's not just about supplements, as we've discussed. There can be lots of reasons.
Yeah, and we know that in the otherwise not identified male factor, there's actually a lot you can do just by changing your lifestyle. Like having a healthy diet, having like regular sleeping pattern, like reducing the stress levels, cutting off alcohol and cigarettes for not even a very long period of time, and it actually can improve the semen quality a lot. So
huge. For the guys, it's short-term pain for long-term gain. That's what I always say.
And you don't have to spend a lot of money on the supplements, because it's always about a balance. I mean, you can actually do harm by taking too
high
many.
dose. Very true. And to those who maybe feel like, I have an impeccable lifestyle, I'm doing everything perfectly, and there's still the sperm issues, remember what we were saying earlier. There could be anatomical, there could be infection, there could be other stuff. So again, it's always the balance. For some people, just stopping hot showers might be enough to make a difference, but for somebody else, they have to go deeper. So there's a lot to consider. Let's bring up the next one here. I've been told I've low AMH for my age. I'm 34 and the AMH was 5. Should I do a fresh embryo transfer IVF or freeze and then transfer on the next cycle? Currently waiting on a consultation with a fertility clinic.
Okay, I think it's most likely there are different units used when it comes to the AMH. So this is most likely picomoles, which
probably
would mean that the AMH is low. I don't really see a difference when it comes to fresh frozen embryo transfers when it comes to success rate, because it's not AMH related. The only from my perspective, the only reason why to freeze the embryos would be if the patient wanted to accumulate more embryos in order to have a bigger family in the future. But again, the AMH tends to be naturally lower in some patients and might be stable for a couple of years. So we don't know whether this AMH will be the same in the future or if it's going to drop. So just to be sure and to have some embryonal backup, doing a couple of rounds of the IVF and freezing the embryos in advance might be a solution.
Yeah, I'd agree, definitely. If they want to add to their family in the future with less stress, and obviously working with younger eggs, it makes sense.
And what I would like to remark also, if the semen quality is good, the image itself doesn't tell us anything about the likelihood of having a natural pregnancy. So, I mean, there are lots of women just having their image tested and panicking that they won't be able to fall pregnant naturally, but they still might.
Absolutely. It is possible. You're kind of walking that tightrope, between obviously not wanting to scaremonger anybody, but tell them, well, if you want to maximize, because of course, you can't be a clairvoyant. You can't see the future and know what might happen if they had, let's say, their first baby and didn't have any frozen embryos, but then life was busy and maybe the AMH did drop and maybe there was an issue in the future. It's just trying to give the best advice that you can based on the current circumstances.
Yes.
So exactly. I totally agree.
You have to see the whole picture as well. So
exactly. It is very important. Next one here. I had first round of IVF with a 5AA euploid embryo. I have 7 embryos and all tested and all 7 came back fine. That's incredible. 7 euploids. I don't think I've ever seen that. My first round worked, but ended in a chemical pregnancy. What should I do for my next round? Or is this going to happen again, another chemical? Wow, 7 euploids. That's incredible.
Yeah, well, that's a very incredible outcome. I mean, unfortunately, I don't have a crystal ball. So I would advise, I mean, again, looking at the whole data that we have about this particular patient. So looking at the medical history, whether there's something indicating there might be some additional immunological problem, for example, or I wouldn't say that necessarily this patient requires some further interventions or any other investigation if she seems to be healthy. So looking at the anatomical factors to rule out any, for example, polyps or myomas or anything suggesting there might be some anatomical issues with the uterus. So it's usually part of the initial.
Probably would have checked.
Also, as I mentioned, medical history suggesting some immunological issues possible. But what is quite important is that the notion that each embryo is unique. Each embryo presents itself with like new immunological information for the uterus. So the thing that one ended up as biochemical pregnancy is quite positive on one side, because we know that the uterus knows how to implant the embryo. However, there might have been some miscommunication between the endometrium and the embryo that doesn't have to repeat itself in the next cycle. So if this was my patient and if I would not see anything like sticking out saying, okay, I need to dig into this and this more thoroughly, then I would advise the patient to go on and try another transfer.
And of course, with a euploid, which I think is important to remind people sometimes, while it's a phenomenal result, let's be real, 7 out of 7 is incredible. That's winning the embryo lottery, even at a young age. It's still not 100% chance success. It's about 60 to 70% typically. I just think it's really important for people to absorb that you haven't failed, your body hasn't failed you. It could be exactly as you said, that unique embryo and the interplay with the internal environment just wasn't supposed to happen. But would you say then, if she went on, as I'm guessing you probably would, if the next transfer resulted in a chemical, you probably would investigate at that point?
Yeah, we usually, I mean, there is no set borderline between what, the repeated implantation failure usually states that there are 3 and more failed attempts, or 2 failed attempts of euploid embryos. So in that case, we would advise to look more deeply into the possible causes for it.
Yeah, of course. But as always, I would also say to this woman, go with your gut instinct. I just feel that's so important. If there's something that maybe a health symptom or something that's been annoying you and you think it's not related to your fertility, just definitely check if it's something that's on your mind, because I think it's awful for people when they have regrets and they feel they could have done something, but certainly with that number of embryos, you should definitely get there for sure. Now there's a few questions from those in a slightly older age category, but I thought I'd pop them in too because they showed up tonight, so we wanted to serve them. So this woman writes, 42 years old, low AMH of 1.6, high FSH of 16.9, trying to conceive. I will undergo IVF next month. Is there any hope? Any thoughts on the Giga red light therapy and if it does assist with fertility? So yeah, there's a lot online about the photobiomodulation. I'm seeing it everywhere. So yes, what would you say to this woman?
Well, I guess my guess is also picomoles 1.6, so it's quite low, judging from the FSH levels, indicating that the likelihood of the ovarian responding to stimulation is quite low. So again, being like my guess, but I would say that I would assume that like 1 or 2x mature ones of a stimulation is most likely what this patient can expect, which is quite low. So the chances, if I was to say some percentage, and of course not knowing the male factor, are around less than 5%, unfortunately, per cycle.
There can be outliers, and of course this is based on not knowing. You don't know until you go ahead with the cycle ultimately, because I think a lot of people say that to me, how do they know how you're going to respond in this cycle? It's like, well, they don't know. It's just based off of the numbers and predictions. But, sometimes you might do better. Sometimes you might do worse. It's just hard to know in advance. And sorry, the additional part of her question, any thoughts on the red light therapy?
I don't have any data on that, but just it should induce some, let's say, vascular flow in the tissues. However, I'm not sure whether it's going to work deep inside the pelvis, if it's going to reach the target organs. So
you have absolutely nailed my concern as well, because I've looked at this a lot in the literature, and I mean, what literature? Like there's mostly literature done in sort of animal studies. There's a lot more done on the sperm because it's much easier to, particularly in vitro as opposed to in vivo. So even at that, if you are doing it, so in other words, the sperm in the petri dish versus with the laser, with the photobiomodulation versus within the testes. But even at that, the sperm are much closer. It's much easier to access the testes than it is the ovaries. So yeah, my take on it, because I've had a lot of people asking about this, it's become very popular, especially with all those masks that everybody's wearing for their faces too, which is great. But again, that's topical. That's the skin up here.
Yes.
To get in that deep, I'm at best neutral on it. I don't think it's going to cause any harm, you would hope, if it's the right spectrum and safe device. But as to it suddenly making miracles happen for the eggs, I'd be very careful of any claims about that.
Yeah, and I wouldn't definitely use it post the embryo transfers, because one of actually the physical factors that we know that might do some harm to the embryo is the heat.
Is heat. Yes, very, very true. Very, very true.
So no sauna, no whirlpool.
No. Very, very true. Very important. And this other question here, which I'm not sure the age of this woman, but we'll bring it up here. So this, she said at the end, I have neutropenia, but was told that this would not come against me in terms of fertility. Is this true? I've undergone 3 cycles of Clomid and 5 of letrozole with 2 beta-HCG triggers. I haven't been successful in conceiving. Should I have more tests done than Hycosi and a Randox full panel? My husband has done DNA fragmentation, which was high at 33% too. So for this one with her issues with the neutrophils?
I would start with the hematological part first. So we don't know what is the reason for neutropenia. I mean, it might be mild. If it's might be autoimmune, so definitely need some investigation on that. I mean, if you're followed up by the hematologist and they say that it shouldn't interfere with fertility, I would trust them on that. But if it's just
because it can just be congenital in some people, can't it? That they just have low neutrophils.
It might just come naturally. It might be the reason for previous treatment, might be related to the medication, etc. So there are various reasons for that. What I understand from the question is that they've tried with the time intercourse, I guess,
presumably,
yes. Also, the DNA fragmentation of the sperm is on the borderline. It's borderline high, 33% usually. Like let's say the cutoff is used by 30%, being anything below. I mean, depending on the method that has been used to identify. So it's between 20 to 30 is the cutoff. So 33 is higher. Usually the DNA fragmentation sort of reflects the DNA quality of the sperm. So I would suggest that with this results, most likely the IVF would be the best solution. Or trying I mean, definitely having the andrologist to consult the results first.
Yeah, assuming there's time, because I don't think we caught the age in that one, did we? Yeah, that's the maths we're doing. There's always the time factor. And I suppose just to add to that, what you're saying about the range, because they had been trying with ovulation induction, essentially. So if you're trying that way and it's not through IVF or ICSI, the percentage of the DNA matters a bit more than because IVF can overcome it to a point and ICSI can further overcome it. So I think, because there's quite a number of cycles, a good number of clomid and letrozole cycles. So therefore, it could well be the time now to be moving in that direction while simultaneously checking in the background to figure out what's impacting the sperm. So you're balancing it all out, because if you've done the bloods and they're okay, well, then hopefully everything's okay on her side. So it's a tricky one. And this person here writes, what are the chances of conception at 44 with donor egg? 2 endometriosis surgeries since the last round of donor transfer. So
well, overall the chances when using the egg donor are around 50 to 55 transfer. The endometriosis surgeries, they also, it's like quite huge, wide category. So don't know whether the endometriosis was mild or peritoneum, or if there were some deep infiltrating endometriosis that might have some impact. So in general, we mentioned that endometriosis actually might have some immunological the impact on the immune response and the way that the implantation is happening. So that's the case. And if after the 2 endometriosis surgeries you don't have any lesions, then the chances should be high up. However, what we see quite commonly in the connection to endometriosis is something that's called adenomyosis, which is like a form of endometriosis affecting the smooth muscle of the uterus, which does play a role when it comes to implantation and later on in continuation of the pregnancy. So that's also something that should be ruled out.
Super important.
If it is identified, there are some pharmacological steps that may be taken in order to improve the chances for pregnancy.
The downreg. So to that person, I would just add that just please make sure that you're seeing a highly specialized gynecologist, because you mentioned 2 endo surgeries, and as obviously Kristýna was alluding to, you could have just ablation, or it could be excision, it could be mild, it could be severe. How appropriately and adequately was it dealt with? Because that's really critical. And I totally agree with what you're saying about the immune side. And, endo is complex. It is systemic. It is not just, there's these bits growing where they shouldn't and we remove it and everything's fine. That's not how it operates. So really, really important to look deeper into that, because it's heartbreaking when donor embryo transfers don't work, because you're led to think, if I do this, it'll fix everything. Yeah, especially at 44. I have a number of donor cases at the moment, and it can be very difficult, very heartbreaking. So do make sure to do all the due diligence for the internal environment before you go for that next round, given obviously the prior one wasn't successful. So I think we've actually got through all the list of questions, which is quite impressive. Well done. Because usually there's a million left. So to anybody, if you felt that there was anything additional you wanted to ask, where would they go to contact you, or at the clinic? How would they proceed with that if they wanted to take things further?
Well, you can either look at our website, or we do have an Instagram account. So
what's
you
the
find
website address and the Instagram?
it's it's gynem.com.
Gynem.com. So GYNEM.com.
Uh-huh.
Yeah.
Exactly.
And then on Instagram as well.
Yes. So you may look us up, and we have lots of information about the clinic and about all the procedures that we use. So yeah.
That's incredible. Yeah, thank you so much for your time and the diligence with which you answered all those questions. I loved all the different topics that we touched on, and hopefully some of the myths that we managed to dispel about, AMH and egg quality, about the importance of the sperm, about what it takes with each cycle, because as you can see, guys, it's not that simple. It's not a black and white situation. It almost never is when it comes to fertility. Yeah. There's always some gray area, but that doesn't mean that you can't navigate it and still overcome the obstacles that are in front of you. So thank you so much, Kristýna. I really, really appreciated that chat. It was lovely to speak with you and to meet you for the first time. Hope to speak with you again. And to everybody else, as always, you know where to find me. I'm the Fertility Detective. You can find me on Instagram. That's where I'm answering DMs and, just helping to allay your concerns and point you in the right direction on this journey and help you to figure out what's what. And of course, you can check out Gynem, GYNEM.com. and ask Kristýna or any of the other team your questions. So for now, that's us signing off, but I'm sure you'll be seeing another one of these brilliant webinars coming up soon. So do make sure to stay tuned to the myivfanswers.com website, because there's tons of helpful information there and lots of people trying to help you on this journey. So with that, I'll say good night.
Thank you. Good night.
Thank you so much, Kristýna. Take care. Bye-bye.
Welcome to